mother herself too. Now, this week, we are going to begin our module 2, which is actually going to transition into the labor and delivery component. So we've talked about sort of the pregnancy piece. We're going into the labor and delivery component. Now, why do we sort of distinguish that as a topic on itself? As we are well aware, L&D is a unit of its own, okay? So we're understanding that this specific moment in time of the pregnancy is a very remarkable moment that we need to really hone in, because there's a lot of more special understanding and knowledge to be acquired, and also better understanding about this very moment could be very crucial for safe delivery as well as preventing complications for both mother and the baby. So today we are going to take a look at the labor and delivery component. Now, just sort of a housekeeping ritual, okay, just to let you know and remind the class that there will be a virtual simulation due by the end of this week. The virtual simulation template is already available under assignment, so you can well be able to take a look at the modules, the learning modules that is required of you to be able to complete the learning, as well as there is a game that is a very interactive and fun game. Now, I do see a few completed submissions for virtual simulations already trickling in, so wonderful, and congratulations for completing it early, okay? But just a reminder for the rest of the class that have not get a chance to do that, the virtual simulation number 1 is due by this week Sunday. Okay, sorry, by this Sunday by midnight 23:59. So please make sure you get that dealt with. Okay, now as usual, just wanted to take a look at some of the other housekeeping component. It's the EAQ module quizzes. Now, as you're well aware, through SurePath, it's already being paced to be released at least a week beforehand. So by this time, module 3 has already been released since yesterday on Sunday. So there is well enough time for you to be able to access and read the materials for preparing for the next module. So for example, right now we're in module 2, but module 3 materials is already made available on SharePath. So you have over a week's time to go over that before our actual class next Monday, and also ready for you to be able to take your EAQ quizzes by next Sunday. Okay, so always remember, the EAQ quiz is due before we have our synchronous class together, okay, which is by the Sunday midnight time frame. Okay, all right, so those are all housekeeping items. Oh, one second, just have to admit. Okay, so those are all the housekeeping items. We are going to dive right into our labor and delivery unit today that marks our module 2. Now, the one key thing here to notice, okay, is the fact that for labor and delivery, this remarkable moment, that real period for the mother and the baby, marks a very remarkable milestone. Not only is it that ensuring that there is a safe delivery, but there's also ensuring of preventing complications that is to come for both the mother and the baby during this time. So really, as nurses, what our role here is the fact that we are both a physiological and a psychological surveillance system here, not only for the mother, but also for the baby. So really what our assessment and nursing interventions and decision making during this time is for both the baby and the mother. So today we are going to take a look at the following topics. We're going to take a look at the stages of labor. We're also going to align that into our nursing process. So what are some of our nursing process? Remember our go-to 4 steps nursing process. How does that look like when it corresponds to the different stages of labor? We're also going to take a look at what are the nursing assessment that we need to pay attention to. For example, true labor versus fake labor, okay? Is it time for the labor to occur or not time yet for the labor to occur? Now, I'm sure you probably have heard of this before, or have heard of it from a family member or even a friend of yours, or however sort of the context would be, is that, oh, I have my a gush of water, like my sac broke, but the water broke, but I was just told by the ER to come back home to wait because I am apparently not ready yet. What does that mean? Okay, we're going to talk about more that in details too, and to also explain what is the physiological explanation behind that. What does it mean by, oh, my water broke, but I'm not ready yet? Or what does it mean by, oh, your water broke, you are just about a 2 degree, but you're still not ready yet. So go home and wait until that you're like at least a minimum 4 degrees by the time that your actual labor. We're going to talk about all of those too as well too. Okay. Yeah. All right. So we're going to take a look at those as well, just to understand sort of the nuances that occurs, whether you are being a nurse in the labor and delivery, or you are the nurse in triage, or whether you're a nurse and in ER, for example, that has sort of that unplanned, unpredicted delivery that is to be expected. What are the assessment related in order for us to be able to properly assess the situation for the proper intervention? And last but not least, of course, is the nursing interventions. But understanding what are the data and what do we need to look at in order to understand what are the appropriate interventions for the mom and or for the baby and or for preparation of the actual delivery itself. Now, something to note is that we are going to take a look and leverage a lot of references from the Society of Obstetrics as well as Gynecologists. They are part of the sort of the golden reference for a lot of labor and delivery associated standards. Now, mind you, even though they are more for medical physicians like gynecologists and obstetricians references, but a lot of those pieces and elements can apply to nursing professionals too. So just wanted to let you know, those are sort of where we reference a lot of the materials in terms of standards of practice, in terms of nursing assessment and interventions. Now, with nursing assessment during this remarkable period of time, like I mentioned, you are monitoring for both the mother and the baby simultaneously, because one changes can affect the other and vice versa. So with that in mind, what are some of the assessment that we need to pay attention to? Keeping in mind, okay, is the fact that there's both subjective and objective data when we're assessing situations, whether it's the patient or the situation itself. So for subjective and objective data, we need to kind of take a look at what are to be expected and what are some of the objective data that can help to reinforce explanation of the subjective data. Okay, so for example, now the catch is that the assessment here, even though we're saying that is subjective and objective, but again, you are assessing for both the mother and the baby simultaneously, and you're going to be required to assess constantly. Okay, because as the labor progresses, while it simultaneously evaluates the mother, you're also needing to monitor the fetal changes as the labor progresses. Okay, so both subjective and objective data are very important. Now, just to name a few, objective data are more concrete, measurable data that is through monitoring, whether it's through machines or systems or devices. Subjective data is really what the patient is reporting to you their feelings of. For example, their pain scale. For example, their symptoms onset. When did it start? How did it start? Those are subjective data. Okay, so very important for us to keep in mind both subjective and objective are equally as important to inform us in our assessment and our nursing interventions. So when we are gathering data, as the patient, okay, as the pregnant lady walks through the doors of the L&D department, they're often very anxious, they're in pain, they're also very overwhelmed. So you as nurses, your role is to quickly sort through the priorities, triage what's going on, take a look at what is exactly happening and whether or not it needs to be prioritized, or it can wait a little bit more because there's other cases that are much more eminently acute than the current case that you're assessing. So it's very important for us to take a look at the presentation of the patient as well as the subjective data. And so, of course, understanding what objective data do you need to look into to inform your clinical decision. So subjectively, you can take a look at narratives such as my contractions are coming and going. The frequency is about every 2 to 3 minutes. It's incredibly intense. They may also kind of tell you about, well, I felt a gush of water just an hour ago while I was sitting on the couch. And then I'm just feeling this intense pain. But I'm going to tell you about, oh, well, my pain is about like 7 out of 10 or like 8 out of 10. The intensity is it's getting worse, it's getting bad, etc., etc. Those are all narrative subjective data. So as nurses, what can we build on or to leverage as objective assessment to inform us whether or not it is getting of a crucial labor progress in the process? Okay, you might want to take a look at electronic fetal monitoring, what we refer to as the EFM. You might want to see if there's fetal heart rates still being very prominent or still very strong, for example, getting faster. Are there palpated contraction, right? Are they strong enough of the intensity that it can be palpated? Also, you can also take a look at what we refer to as the dynamometer monitoring, because that will give us a readings of the fetal monitoring simultaneously while the labor is in progress. Okay, so those are some of the tools that we can kind of make ourselves getting familiar with to be able to know, okay, these are what I'm hearing from the mother, subjective data. Those are what I can leverage as tools to be able to obtain objective data to let me know whether or not the labor process is actually progressing. All right. And at what stage would is it be? Does it require immediate attention, or it can wait for a little longer, for an hour or two, once the progression goes in more? Okay. Now there's also tools, right? But there's also skills that we can look into. Let's, for example, like the Leopold's maneuver. There's also a lot of palpitation that you can take a look into to look at the positioning, etc. All of those are objective data that can help us as nurses to inform us whether or not, yep, I think the labor is progressing to the point where we need immediate attention. Now, in addition to that, while there's a long wait of this process, okay, as we're going through, oh, I noticed that, Andreen, there's lots of students on the other link we used in week 1. Okay, okay, no problem. So if that's the case, should I send a quick announcement to the class about our current link then? Give me 1 second, okay? If that's the case too, don't worry. Give me 1 second. I will send a quick announcement to the whole class just so they know where to come in. Okay, give me 1 second, okay? I'll be right back. 1 second. Thanks for letting me know. Hey, good morning, everyone. I just sent an announcement very quickly, so I hope that reaches everyone during this time. So Okay, no problem. Okay, no worries. Everyone, if you are just wanted to bring to your attention, okay, the technically, if I'm using the exact same meeting link, eventually the recording of the meeting report, it's going to exceed the capacity of Google Meet. And that's the reason why, unfortunately, I have to create new meeting links for each week for our synchronous class. But don't worry, just wanted to let you know, okay, if you go on Canvas under modules, you will be able to see a actual module there that says virtual classroom link. And once you click in there, the link is already been established directly for you. Okay, so let me just bring you over there. I'm just going to and bring you to the, okay, give me 1 second. I just wanted to show you very quickly. Okay, 1 second. Okay, everyone, just to prevent just to prevent our struggle that we've just experienced today, okay, if you take a look at Canvas, this is exactly how you see on Canvas right here. When you actually, well, this is our homepage, okay? This is our homepage. But when you go through to the modules where you would typically see, you would find the resources and also the PowerPoint slides, etc., that we have, you will see that at the very top, there is a virtual classroom with meeting links. So once you click in there, all right, I've already organized a table with the meeting link associated to that week. So for example, this week, May 25th, okay, if you click here right there, it's already a link directly to the Google Meet meeting already, okay? So it's already organized here for you for those weeks that we are meeting together for synchronous classes, okay? So you can access right there for the meeting link. So I apologize, I can't be using the exact same link because of Google eventually will boot me out when the capacity of the recording, well, not the recording, but like your attendance log and things like that will eventually exceed capacity. That's why unfortunately, I would have to make new meeting links for each week as we are meeting synchronously. Okay. All right. Now, since we're on here, I just wanted to walk you through. We do have another class next week for June 3rd, okay, June 1st, sorry. And then the week after will be test number 1. Now, there is no Google links there. Reason being, we're not, even though there is the test taking place synchronous online on Canvas, but we're still expected to log in during the same time. So there wouldn't be a class during the week of the test, all right, because I would need to invigilate the test number 1 online. So there wouldn't be a class, but there will be a recorded lecture for that week, okay? Just so you know, all right, there's a reason why these are blank because those are the weeks where the test takes place. And then the very last week, unfortunately, it's the civic holiday. And then this week, unfortunately, it's also asynchronous because of the content to get ready for that. It will also be recorded as well. So not too worried. I will get you reminded the week before. All right. But just because I'm on here already, I might as well just give you a quick heads up in regards to the scheduling already. But it's already all organized here for you on Canvas. All right. Okay, awesome. So I'm going to switch back over to our slides. 1 second. Okay, so just to continue on in regards to the gathering of subjective and objective data. So we talked about what are some of the tools that we can use, and we're also going to have just mentioned some of the skills like the Leopold's maneuver, sort of the palpitation of the contraction itself, the fetal positioning. We'll also talk about. We're going to talk about more in details later, but just to highlight some of these elements in order to understand what are subjective versus objective data as we gather them through our nursing process. Now, important to note as well too is that there are some crucial alerts to be mindful of, where it indicates to us that it requires immediate attention because of the positioning, for example, that may pose risks to the baby, and or that the subjective data that you are receiving from the mother herself is deteriorating or is worsening. Sometimes it's very important to note that even though the subjective data may be indicating a deterioration of the condition, it does not necessarily mean that the labor process is progressing. Okay, so it's very important for us to sort of tease apart, and that's exactly the reason why we say L&D, labor and delivery, is a specialty of itself. Okay, because typically when we are dealing with other patient population, when you notice or receive deteriorating conditioned narrative data, you will be expecting that the patient's condition is deteriorating, and which means immediate attention is required. But in labor and delivery, sometimes that might not be the case. Yes, it may refer to a deteriorating condition of the mother, but it doesn't necessarily mean that the baby is ready to be delivered. Okay, and so it's very important for us to kind of tease apart: are these symptoms more for the maternal, the mother, or are these symptoms that we are observing or collecting objectively are more related to the baby, the fetus? Okay, so it's very important for us to tell apart, and that's exactly why we have a module the component of health history and admission triage. Okay, now it's very important for us to keep in mind that there is two simultaneous process happening here. Okay, as you're triaging the patient, whether or not it's ready to be delivered, or no, there needs some time to wait because it's not ready for labor, there is a lot of things happening simultaneously. You're not just collecting subjective data and or objective data, you are also collecting health history that are both subjective and objective. Now, if you take a look at the screen right here, for these actual health history, you're going to obtain a thorough history in the phases of perinatal as well as the maternal health history. Okay, now for example, what is the frequency and timing of the contractions? When did it start? What is the status of the amniotic membranes? Has there been a gush of water? Has there been a felt of amniotic fluids? Is there a contractions being true contractions, or they are fake contractions, which we're going to talk about that in just a little bit more in detail, or what we refer to as the Braxton Hicks, which is not true contraction. Okay, now we're also going to take a look at some of the admission triage elements, which includes, okay, the expected date of delivery. Okay, is it time yet, or is it not? Is it too early, or is it on time? Relatively on time. Now, the key here is expected day of delivery is always just a prediction. It is never 100% accurate calculation. All right. So it's very important for us to keep some flexibility of, well, you are like 1 full week too early. None of these calculations can be 100% accurate. So keep that in mind. And also, what are the current gestational age, right? Is the baby 7 months? The baby's 8 months. It's the baby full term in 9 months, or short of, a little bit shy of 9 months, okay? Very important for us to know what the gestational age of the fetus is too. Now, if the patient is present in labor at a 33 weeks, okay, you're looking at a preterm emergency, because remember, 33 weeks, not full term yet, right? So you might then immediately need to prep the the patient into a emergency attention, because preterm pregnancy can pose risk for both the baby as well as for the mother. Now, also very important to note, as you can see here, are what we refer to as the maternal screening status, the GBS. And alternatively, you also need to analyze their GT-PAL profile. And what do they stand for? It's very detailedly written in your textbook readings, okay? G stands for gravida, which is the total number of pregnancies that the mother had to date, regardless of outcome. Whether there was a miscarriage, whether there was a abortion, whether it was there is a unfortunately ectopic pregnancy that needs to be induced, therefore leading to death. It doesn't matter. Gravida refers to how many times, the numbers of times that the mother has been pregnant, regardless of outcome. And T stands for term birth, which means that there has been deliveries as a result of these pregnancy of 37 weeks or higher or more, okay? And those are what we term means that pregnancy carried to term. So T stands for term. So it could be that the patient has 5 gravida. So G5 means that she had 5 pregnancies, but there were only 3 Ts, meaning there's only 3 that were carried to term for delivery. Okay. Now, P is what we refer to as preterm births, which is deliveries from 20 weeks up to the 36 weeks. Okay. Those are what we refer to as preterm gestation. And A is abortion, or miscarriages. So pregnancy that ends before the 20 weeks mark is considered as A. Okay. So it's at A1 or A2, for example. L is living children. So the actual number of children that are currently alive as a result of the numbers of pregnancies, okay, is referred to as L. And this is what we refer to as the GT-PAL profile, okay, which give us a lot of information about the mother's maternal profile, okay, the obstetric history of the maternal profile. Now, why are these information matters? Okay, but of course, last but not least, you need to make sure that you're asking for their current statuses, their conditions, right? How are they feeling? What are their symptoms that they're experiencing? What are the fetal movement, for example? How do twins and triplets get recorded? Excellent. Still consider as one pregnancy because it's still within the same pregnancy. Okay. However, in terms of L as a living children, it will then be referred to as 2 or 3, depending on the twins or triplets. Okay. So the pregnancy of numbers of pregnancy that stands for G, the gravida, will remain the same. It's accounted as 1, whether it's delivered as twins or delivered as triplets. Okay. But the L number, which is the living children number, will then be as 2 or 3, depending on. Okay. All right. And Anne has a question. Go ahead.
Winnie, that's a good example about the twins. I'm just curious
Yeah.
if, let's say, the twins were born at term,
Yep.
would you say 1 for T as well?
Exactly. Yes, because
Okay.
it still considers that one-time pregnancy, though the living children itself is more than that one time.
Okay, thank you so much.
Yes, no problem. Yep. So it's very important for us to understand the acronym, because what they stand for, because oftentimes you will see this GT-PAL profile on the patient's chart. Okay, whether it's through the EMR, the electronic medical record, or it's through their clinic, their obstetrician's clinic's profile. The GT-PAL profile is very important for us to have an understanding of what it stands for and what does it mean, right, in terms of its acronym. Okay, so kind of coming back again from the questions, excellent questions, guys. Why are these information important to us as part of the nursing assessment? Now, understanding the fact that this obstetrical history will give us an understanding of whether or not the patient right now is actually at high risks for complications, whether it's delivery complications and or post-delivery complications. Okay, so it's very important for us to have an understanding of that obstetrical history, because that will give us and inform us part of the elements of decision making of whether to anticipate it as a high risk labor complications or even postpartum complications. Okay, now finally, we're going to also take a look at the blood screening. So, of course, blood tests. Okay, now during this time, a lot is happening simultaneously. As I mentioned, not only is your assessment happening in various simultaneous realm, but there's also a lot of tests that are under way during this time simultaneously. And part of that is the maternal blood. Oh, sorry, just need to admit someone in 1 second. Okay, all right. Now, The reason about maternal blood screening as being important is because oftentimes, or well, hopefully not oftentimes, but there can be situations where the mother is not aware of her Rh blood factor. Okay. Now, just to hone into this a little bit deeper, okay, Rh blood factor is an important piece of information to be aware of because remember, the fetus, the baby, shares the same blood as the mother's body. If their blood type between the mother, the maternal body, and the fetus has actual clashes between each other because of their Rh factor, okay, it can be a very dangerous pregnancies, which requires diligent monitoring as well as interventions throughout the whole pregnancy. Because there is no 1 second in time that the baby and the mother do not share blood across the membrane barrier of each other. And so if their blood type are actual clashes of each other, the pregnancy itself can be super dangerous, okay? Let alone the labor and delivery component, the component of the process, right? So it's very important for us to understand, depending on where is your involvement along the pregnancy stage, it's very important to be well aware of whether or not there has been a maternal blood screen information available in the patient's profile. That is the exact reason why. If the maternal's blood type is a clash with the fetal blood type, immediate interventions is required in order to ensure the pregnancy can progress safely to terms. In addition to that, it's also very important to have that information because that will be fundamental basis for a safe labor and delivery part of that component in the process. Okay, so whether the mother is Rh negative or the baby is Rh negative versus a Rh positive, vice versa, those are clashes of blood type. Immediate attention is required. Okay, of course, like I mentioned, we prefer this to be learned and are aware of well in advance. Okay, even before pregnancy, and even during the early stage of pregnancy is the best because then you can have better assurance and chances of safe pregnancies when there are intervention in place. But there are cases where that is not known until the second trimesters, and that it's actually going to be very dangerous for both the mother and the baby. So it's very important for us to know the reason why maternal blood screening is very important for both the maternal health as well as for the baby, and also ensuring whether or not the pregnancies can be carried to term. All right, so it's very important too. Now, in addition to blood type, there's also other screening through the blood test, the maternal blood test. We're also going to look for Hep B infection. Is there active Hep B infection or not, or there previous Hep B infection through antibodies being identified. Also very important to check also for infectious diseases such as HIVs or rubella as well too in the blood, because again, those can be transferred through the blood-brain barrier between the fetus and the mother's body. So it's very important for us to be able to flag those in the maternal blood screening profile too, in addition to that. Okay, now moving on to, let's take a look at one of the most vital screening is actually Hep B. Now, it's also the GBS, sorry, not Hep B, but the group B streptococcus infection through the maternal blood screening, because we need to be well aware about this as as a reason for a Canadian protocol. Now, this is a protocol in Canada that we're very well aware of, okay, that we need to be very mindful of. Reason being, in Canada obstetric practice, okay, according to our Society of Obstetrician and Gynecologist, GPS prophylaxis is a standardized quality and safety metrics, okay? GBS is a germ-positive bacterium that can colonize the vaginal and anorectal tract of about 15 to 30% of healthy pregnant individuals. Okay. Now, you may say, well, the number is not that high, so why should that be a standard protocol? Reason being is that typically, even though the mother may have been infected, oftentimes is asymptomatic, which means that it does not harm her. However, once the baby passes through the vagina tract for delivery, through the birth canal, that bacteria can ascend after the membrane have ruptured, and the newborn baby can aspirate that bacteria in the fluids, which then again lead to what we refer to as a early onset neonatal GBS sepsis. This infection can lead to sepsis of the baby, pneumonia, as well as meningitis within the first 72 hours of life. There's a reason why this is now a standard protocol, not because it affects the mother, and as in fact, like I mentioned, it's often asymptomatic for the mother, but it can cause and pose significant risks to the baby at birth within a very short amount of time, 72 hours upon birth. Okay, so as per the Society of Obstetrics and Gynecologists of Canada guideline, there's screening, it's required, okay, regardless whether the mother has reported any symptoms or not, because remember, it's often asymptomatic, okay? All right. So Andreen said, yes, more women has it than those who doesn't. Exactly, because it's often asymptomatic. That's why it's very important for us to be well aware that this is a standard protocol that needs to be screened, because universal screening will help us identify those individuals that does have the infection, but then we'll be able to then intervene accordingly. Because what happened is that once that is identified, there can be antibiotic that can be provided for prophylactic antibiotic treatments, okay, to be able to produce and prevent that from happening in anticipation for the labor and delivery to happen. So this is exactly what we refer to as GBS prophylaxis. There would be a program of antibiotics being prescribed to help prevent that to happen, especially when that screening has identified the mother to have had the GBS infection. Okay, so very important to keep that in mind. Now, we've talked about those sort of obstetric history, those health histories, the health assessment. We're going to now look into when the time is getting closer and closer to the actual labor. How can we tell the difference? Okay, how can we take a look at whether or not, okay, this is really going to happen. The labor is imminent within the next hour or so, okay? And or whether or not, yeah, no, some more time can be waited, okay? How can we understand that? Well, key thing is to understand the differences between true versus false labor. Okay, now oftentimes it's very common for us and also for patients to arrive at the unit being convinced that, oh, this is it, it's time, it's like I feel the intensity of the contraction, it's getting more frequent, and the intensity is increasing, but then only to be sent home and say, no, you're not. Well, how can we tell? Okay, so there's also I saw a question, just wanted to flag that first. If GBS is positive, do they proceed with cesarean or still vaginal? Okay, so the question is, if there is a detected GBS infection in the mother, do they still proceed with cesarean or just allow a vaginal birth to take place? Remember, if the universal screening happens early in time, okay, that it's well identified, well in advance in time, antibiotics would be prescribed to the pregnant woman in order to treat the infection, which means that is in preparation for a vaginal birth. Because remember, cesarean in the protocol of the health system in Ontario, it's not a mandatory procedure. Cesarean, it's only considered when it's medically necessary. Now, you may argue, well, if there's a GBS infection, of course that's medically necessary. Yes and no, okay? Because if the infection is treated and is under control by the course of antibiotics, that it's not considered as a medical necessary, okay? However, like I mentioned, if these screening aren't done in time or well in advance before the actual labor to occur, now this is going to be a very significant clinical decision to be made. Reason being, if they only identified the GBS infection immediately before the patient is going into labor, that in itself will be deemed as medical necessary, then a cesarean would be considered. But otherwise, if the universal screening of GBS has been done well in advance, course of antibiotics has been prescribed for prophylactics, okay, you do not need to worry about whether or not it needs to be cesarean or vaginal birth, because the course of antibiotics would have had controlled the infection itself. Okay, you can do prophylactics 4 hours, but exactly. But like I mentioned, if it's only been identified immediately before labor, then yes, that could be a clinical decision to be made for cesarean. Okay. But let's just say, because like we mentioned, the labor process can be long, right? But again, that depends and varied, because some labor could be just well under 2 hours. Some labor can last for 10, 12, even 15, 20 hours. Okay. So it all depends on when that identification is being made, right? So it's all depends. That's why we say this labor and delivery process is all a simultaneous decision making based on the objective data that you are gathering throughout the process. Yes, Andrea, you have a question. Go ahead.
GBS has to be done for each pregnancy, right? Like you can't just
Each.
say, oh, because the patient didn't have it in their last pregnancy, they don't have it now, right?
Exactly. Yep. It cannot be
All right.
assumed. Yes, exactly.
Thank you.
Yep, no problem. Well, and that's what we refer to as universal screening, right? So it's it's been pushed as a standard guidelines that GBS screening is a universal screen that needs to be done by the gynecologist and or the obstetrician, okay? Because typically, depending on when the patient is seeking medical care, right, they either see a gynecologist or they see an obstetrician. So this universal screening of GBS infection is being pushed as standard protocols, okay, to obstetrician and gynecologists to screened, because that is with the understanding of that creates complications for the baby, as well as, right, that creates risks to the baby, that it's needed to be done way ahead of time. Okay. But like I mentioned, a lot of differences of cases can happen. Not all cases will be connected to an obstetrician very early in advance or connected to a gynecologist early in advance. And so just wanted to let you know, we do say in ideal situation, these screenings are done well ahead in time, but there can be cases too where these do not happen well in advance. Okay, as a standard screening, which week do they perform? Okay, typically, according to the guidelines from the Society of Obstetrician and Gynecologists in Canada, they suggest this to be done well before the end of the first trimester. So we're typically talking about latest by the 10 weeks time or the 14 weeks time, because remember in our last module, each trimester is give or take about 10 to 14 weeks in duration, right? So if we're honing into hoping that these standard screening will take place early in advance, we always prefer that to happen during the first trimester. So typically what we say is hopefully before the 10 weeks mark, because sometimes, remember, symptoms due the morning sickness often don't start until probably by the first month, like the 5th to 6 weeks mark. Remember, the morning sickness typically don't start between until the 5th to 6 weeks mark, right? So that in itself, it's give or take about a week, a month already. So just wanted to kind of keep that in mind, is that we'd say first trimester, the latest we would like this universal screening to take place is at that 10 weeks mark. Okay. Now, but like I said again, lots of varying different cases, right? Not all cases would be connected to an obstetrician and or gynecologist well in advance. So just what we say, as early as possible. Okay. All right, now let's take a look at the true versus false labor. So like we mentioned, as time passes, okay, now as the mother is progressing into the labor, okay, more closer into the actual labor moment, we need to be able to come prepared, all right, to be able to distinguish between the true versus false labor. Now, let's take a look at the physiology of false labor, which we often call the Braxton Hicks. I'm sure you've heard of that before too, right? From your friend, from family member, or even in the videos that we have shared with you through on Canvas too. These are what we refer to as false labor. They are irregular. They are uncoordinated contractions of the uterine lining, okay? They're typically non-productive, meaning what does that mean? They do not exert enough downward pressure, okay, to alter the cervix as a preparation process for the labor, if it was a true contraction. Okay, so the pain or discomfort that the mother is experiencing due to Braxton Hicks, okay, is typically lower front sorry, I can't speak today. Sorry, abdominal area and or the groin area. So sort of the front end of things. Okay, now how can we tell that the Braxton Hicks, if that area, that lower abdomen area, it's supposed and expected to feel the pain and discomfort, right? Crucially, Braxton Hicks contractions are also very responsive to environmental changes. So for example, okay, if a patient is dehydrated, the uterus will become irritable and contracts even more but then if you give the mother, let's say a glass of water or even 2 glasses of water, okay, the contraction will reduce in magnitude or potentially stop even, okay? That in itself, it's a good indicator to let us know that that contraction, those contractions that the mother has experienced are Braxton Hicks contraction because it responded to environmental changes through a glass or 2 glasses of water, okay? Now, or if you ask the mother to be on their feet, okay, because they've been sitting too long or they've been just lying down for too long, just ask them to stand up for a little bit, okay, for like a good 2 to 5 minutes. You will also notice that like, oh, okay, I think the contraction is not as bad. Those again is giving you a clue about that is potentially Braxton Hicks contraction because again, environmental changes and they respond to environmental changes. Now, on the contrary, as you can imagine, or as you can guess, true labor will not respond to environmental changes. In fact, it will just continue to advance in magnitude, which means the pain level will continue to increase, the contraction frequency will continue to increase, okay, and the magnitude of the contraction will continue to increase, regardless of whether the mother is standing or sitting or drinking a glass or 2 glasses of water, okay? Those would be as clues for us to know are true labor, okay? True labor is, again, understanding the physiological changes of it, is that it's a powerful neuroendocrine feedback loop, which means our body, the patient's body, would release oxytocin from our posterior pituitary gland, which then bind to the receptors in the uterine muscle, which increases the force and magnitude of the contraction itself. So that's the reason why you may have heard, time to administer the oxytocin, time to administer the oxytocin. Why? Oxytocin is a induction helper. Okay, well, not induction, it induces, okay? It's a hormone that helps to induce labor, all right? Oftentimes, you probably would be sort of through your experience or even through watching movies, okay? Is you'll notice how the mother has been in labor for 10, 15, 12, even 20 hours. And then the physician comes in and say, you know what, it's been too long. It is an increased risk for the baby to be in there for too long for false labor. We need to induce the delivery, Okay. And that's typically the time when you will hear to oxytocin infusion. All right. Then oxytocin would be infused in the mother's body in order to induce labor. Okay. Because it's a hormone that will be affecting the uterine muscle in order to increase the magnitude of contraction and also the frequencies of its contraction in order to advance the labor process. Okay. So oxytocin, key piece to remember. This will trigger contractions that are more heavier in magnitude, so stronger contraction. They are regular rhythm, because remember, Braxton Hicks are uncoordinated contraction, but true contractions are often rhythmically regular. Every 3 minutes, then every 2 minutes, then every 1 minute. Okay? They have a very rhythmic regularity in true contraction. And then it will progress and advance into the labor process, which will mean that, okay, it is time for the labor to take place. We either need to wheel the patient into the birthing unit, or maybe they're already in the birthing unit that they've been waiting for a birth to occur for hours on end already. Okay, so it's very important to be able to ask for the subjective data. Is that how long has it been the contraction? What's the frequency of the contraction? Because that's typical health teaching that we do to patients and to the family, right, especially their spouse, is to learn how to calculate the frequencies of the contraction, time the frequency, because true contraction will always be a regular rhythmic contraction every 10 minutes, every 5 minutes, every 4 minutes, right? So just to keep those in mind, those are also very important health teaching too for the mother as well as for their family, the spouse. Okay, so Anne has a question. Is false labor the same thing as pre-labor stage, or are they distinct events? They are different, okay? Now, pre-labor stage are a very, you can say pre-labor stage is basically the moment before the actual labor is expected. False labor is not false labor. We're referring to as false contraction, can happen throughout the whole time because, like we mentioned again, the labor process can vary in duration from person to person. Some people, especially if it's not their first pregnancy, their labor process can be significantly shorter. Okay, for example, they may only take 4 hours or 5 hours before the actual labor is ready and the birth takes place. But some pregnancies can be taking 10 hours, 12 hours, or even 20 hours, okay, for the labor process to wait until the actual labor moment, okay, until the actual birth actually takes place. So remember, this is not fake labor. This is just what we refer to as a fake contraction during that waiting period before the actual labor is about to take place, okay? So Andreen has another question. In triage, do we ask about last meals or what they had to eat in the last 24 hours? Because I know some foods can cause false contractions too. Yes, absolutely. But this doesn't really matter. When the contraction becomes, so it does matter when you're distinguishing between is false or true contraction, okay? Because that can explain the Braxton Hicks, right? Which is the fake contraction. But as the contraction itself, it's getting more regular, which means we are already being able to tease it as, oh, it is true labor, true contraction. When it's 10 minutes, 5 minutes, it doesn't really matter about what they have eaten, right? Because the food itself, it's only a important element for us to know to distinguish whether it's false contraction or true contraction. But as the mother is already progressing into true contraction, it really doesn't really matter, okay? In fact, we encourage some food intake during the wait time too, because we don't know how long it's going to take, but preferably we do not encourage for something that's very hard to digest, or like we always encourage for just light meals, right? Like light food, like drinks, or anything that is easier for digestions, because again, the pain in itself may already suppress the appetite of the mother, but we also need to ensure that there's enough caloric intake for the actual labor process to take place, the energy, the stamina, etc. Okay. So there's another question, UG said, can false labor occurs as early as 20 weeks? It can, but again, those are what we refer to as Braxton Hicks. Okay, it's not false labor. We need to make sure that we're using the right terminology. We're just saying that it's false contraction. Okay, but it doesn't indicate that it's actually getting into labor stage just yet. Okay, so yes, it can happen at any time after the second trimester. So you typically won't hear about Braxton Hicks occurring in the first 2 trimesters of the pregnancy. They're typically with, like, let's say the about sort of the what we refer to as the third trimester, like sort of in the later half of the third trimesters, would the Braxton Hicks be typical to be as early to be experienced by the mother, but typically you would not be expecting that during the first 2 trimester. If that is the case, we know that's a red flag, that it's an emergency and requires emergency medical attention. Okay, because that likely is going to be a preterm emergencies. Okay, so keep that in mind. Yes. Okay, excellent. So now coming back to sort of the true and false contraction here, okay? So we mentioned true contractions are very typically rhythmically regular, okay? So it's very important as part of our health teaching. They need to know how to time the contraction. Is it every 10 minutes? Is it every 8 minutes? Every 5 minutes? They need to be able to know how to time the frequencies of it, okay? Because the pattern is distinct. It typically originates, okay, a true contraction. Remember, Braxton Hicks is usually the front abdomen and near the groin area. Now, the pain area between false contraction versus true contraction is that true contraction will be experienced in the lower lumbar back region that sweeps across, okay, sweeps across the mother's abdomen like a tightening band. So it kind of stemming from the lower back, and it goes and it radiates, okay? It goes all the way to the front of the abdomen, okay, like band. And this will not subside regardless whether the patient's standing, sitting, or walking. It does not stop. It does not get better, okay? It will only get stronger and stronger magnitude and more frequent, okay? Now, sometimes though, for some, not all, they will report to you is that when they walk, okay, they feel it even more intense. Reason being, remember, we live with the force of gravity. Gravity may actually cause the contraction to be intensified when they are walking, because it creates that downward pressure, right? It adds to that downward pressure that the oxytocin it's already doing in itself, right? So gravity, so some patients may report to you when they're walking, it makes it worse, or when they're standing up, it makes it worse. But remember, it does not get better, right? Because true contraction would only get more and more stronger, more and more frequent, because that is an indicator to us that it is getting closer and labor is around the corner. Okay, so question of what frequency of contractions do we know the mother is in full labor? Well, typically we say when it's about less than the 10 minutes mark, okay, like when it's 8 minutes, 6 minutes, we're typically already going to wheel the mother to the birthing unit, because it's eminently a solid sign that labor it's in place. Okay, so we would say anything under the 10-minute mark. Okay, I typically would err on the side of cautious anyways. Anything under 10-minute mark, it would be around time to it would be the time of indication to wheel the mother into the birthing unit already and be prepared for the actual labor itself. Okay, now some of the other diagnostic tool that we also need to emphasize on besides the contraction itself to tell us whether or not, yes, labor is imminent, okay, it's time. We also need to look at some of the diagnostic thresholds too, right? So for example, the true and false labor is, again, progressive changes, okay? And also the dilation, right, of the cervical changes, like how much has been dilated. Also too, the more dilation it is, the more eminent of that as an indication that labor is in place, all right? Also too, when the contractions begin to occur at every 3 minutes mark, you're pretty much going to expect the labor is going to happen. Okay. So like I said, I tend to err on the side of cautions. Any contraction frequencies below 10-minute mark, I would get ready. Okay. I would prepare the process to get ready for labor to be expecting. Now, the other two would be is that you also wanted to make sure that there is an understanding of the fetal position too during this whole time. And that's exactly the reason why I mentioned frequent assessment is very important, because the fetal position will determine the likelihood of complications as well as potential complications for the birth process, because the fetal position can be a detrimental factor. Now, how do we know what's the fetal position? Is it for us to is it for us to assess things like that? Yes, we do, or we are able to assess the fetal position. We will talk about that in just momentarily, so bear with me, okay? Because if the contraction is getting faster and faster, the magnitude is getting stronger and stronger, but the fetal position, okay, is not in the right position, that is still going to require immediate medical attention. We do not wait longer, okay? Because especially during the time, even though we'd be like, oh, my contraction is only every 12 minutes, if the fetal monitoring is showing the vital signs of the baby being of concern, the fetal position is also of concern, that will not be weighted. We're not going to tell the mother to say, okay, just tell us again when your contraction is less than 10 minutes. No, 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 no. If the fetal monitoring vital signs is telling us otherwise, that there is concerns about the baby, even though the contraction might not be ready yet, we do not wait. All right? Because remember, like I mentioned at the very beginning, you are assessing simultaneously the mother and the baby, because changes of either one of them will affect one another. So in this case, if the baby's vital signs is of concern, you do not wait. It doesn't matter how frequent the contraction is, how light the contraction magnitude is, it does not matter. Attention right away. Okay, so it's very important for us to keep in mind that is the part of diagnostic threshold that we need to keep monitoring on a repeated, continuing basis throughout the whole process. Okay, so typically what we refer to as, at least for the context of this course, okay, we're not expecting you to go really into the clinical details and knowledge of it, but just so you know, you are assessing both the mother and the baby, and if any side are showing abnormalities, you do not wait. Immediate attention right away. Okay, so nursing intervention here in the context of our course, okay, is really assessment. What do you assess for? What do you look for? What do you need to know in order to know what to assess? Okay, and also when to intervene and how. Okay, so if there's any concerns with the fetal status, any concerns with the maternal status, we do not wait. Immediate attention. All right, Andreen, you have a question?
Yeah, sorry about that.
No worries.
So based on videos and so on that I've been seeing on social media, with patients being in active labor and nurses asking them triage questions and so on, based on your standpoint, like if someone's having contractions like every 3 minutes and they come in, is it that we should ask is it that we should just not do triage, or there's certain questions that we would not ask, or how does that work?
Okay, so I'm assuming you're asking if the contraction, because you mentioned if the contraction is like every 3 minutes already, right? That it's already at the labor stage, right? Like we do
Right.
not wait anymore. Okay. We do not wait anymore. The whole process is going to get started, right? We're just going to wheel the patient right into the birthing unit because the labor is going to start, right? Or in fact, labor has already started if the contraction is already at 3 minutes frequency. Okay. So just to keep that in mind. But if you were to ask the question in the sense of, well, the contraction, it was every 12 minutes apart. Okay. Are you still going to ask those questions? Is that what I'm getting from the question?
Yeah, like if someone comes in active labor, I'm sure you've seen like some videos online. You know, the lady came in, she was in a lot of pain, and the nurse there, she was just not wheeling the patient to the because I know you can ask some triage question while you're taking the patient to labor and delivery,
Yeah,
but
yeah.
they were just sitting down there asking the questions. The lady was in a lot of pain, screaming and whatever, and the nurse was just going about her business. So is it that all the questions for triage is important, or if the person is in active labor and you're wheeling them in, is there certain questions that you have to get answered and you just try to get those out the way and then leave the others until after? That's what I'm getting at.
Okay, I hear you. Okay. So I guess I'll answer it this way, okay? Whether you might, I guess from the viewer perspective, because you mentioned it's on social media, right? From the viewer perspective, especially us as nurses too, looking at videos like that, we may ask the question of, oh, well, shouldn't something be done? Or like, the lady is yelling and screaming in pain and things like that, right? So remember, like I mentioned, every case is different of how long the actual waiting of the labor process takes place, right? So, but why would the triage nurse in the video on social media look so calm and like, like not even really asking questions? Now, there's two parts to this. The first part is to understand, remember we mentioned that there is fake versus true contraction. Okay, the Hexton pricks can happen at any time during the third trimester, typically sort of the mid to the late stage of the third trimester. Okay, would Hexton pricks be experienced? Okay, but it's important for us to keep in mind is that although yes, Braxton Hicks is experienced, which is false contraction. All right, is there imminent risks that we need to worry about? So for example, if the patient comes in just yelling and screaming, but there has been a motor vehicle accident that was in place and that induced the contraction because there wasn't any contraction experience before the actual motor vehicle accident, right? So there's a lot of things to consider when it comes to whether or not what are the true important questions, because first of all is you always have to worry about, is there safety concerns for both the mother and or the baby, right? If yes, then you need to then look into, is labor going to happen within the next 30 to 45 minutes? Yes or no, right? And if that's the case, you also have to worry about too, is that if the contraction does not correspond to the gestational age of the pregnancy. For example, if the lady is only pregnant for 6 months, which is, kind of like at the beginning of the third trimester, like, end of the second trimester, but the contraction is already sitting at every 8 minutes. You know that this is likely going to be a preterm emergency based on those two things combined, right? Preterm gestational age, magnitude of the contraction itself does not correlate with each other. That it's going to indicate that's a preterm emergency. So you don't wait. You're not going to ask. You're not going to wait. And you still ask questions, but you're not going to wait. You're not going to have as much of that patience, right? For example, and then so it's very important to keep those in mind. Okay, and then oh no, the mother had the baby 5 minutes after. Okay,
No, seriously, it was a case in the US,
yeah, yeah.
and like the woman was literally screaming like every 3 minutes or so on, and the nurse was just not giving, she didn't care, like based on how slowly she was asking the questions and how slowly she was moving. And the mother literally had baby like 5 minutes after. They didn't take her into a room to say, okay, just in the event something happens, or put her onto the monitor and probably ask the triage questions in the room.
Mhm.
Nothing like that happened. So that's why
Okay.
I'm asking like all
Well,
these questions.
so you know now, right? It's like, what could be done? Well, you ask those questions, right? The GT PAL profile, you ask the question because you
Right.
probably won't have the information on hand, right? You would
Right.
rely on the patient to tell you, right? You're going to have the fetal monitoring attached to the mother already, right? Ask her when's the onset, what's the magnitude, the frequency, and all that, right? So
Okay.
now you know, right? Since after we've learned all the content just now you know what you would have asked if you were the triage nurse. Okay,
Okay. Thank you.
so I would say, is there questions that you have to ask mandatory? I would say all of the questions that we have talked about today are mandatory questions, but when to ask what matters based on your clinical judgment, right? So like, for example, if, like I mentioned, if the gestational age is only 6 months, but then the contraction is already at every 8 minutes, that doesn't align, right? So that it's an indication to us there's likely a preterm emergencies here. So we need to have a medical attention right away. Or you're talking about, okay, well, this is likely Heston Bricks. Like, can I give you a glass of water? Why don't you stand up? Why don't you walk around? And then the patients report to you, okay, yeah, no, I feel a little better now. Then you know that's a Heston Bricks. That's a false contraction, right? So those is like, I would say all of the questions that we have learned right now, well, not question, but all of the content that we learned right now are all important, are equally as important, but it depends on when and what the situation is and what would you ask at what time. Okay, so important for us to go through all of these, right? That's the whole reason. Okay, so now true versus false contraction. Now I'm going to just hone into also the physical assessment, because remember I mentioned about the fetal positioning, because remember the fetal positioning itself, it's a crucial determining factor for whether or not this is going to be at risk birth delivery or not. Okay, for both the mother and for the baby, we need to really be able to understand what are the difference between those different orientation of fetal presentation. So aside from the actual contraction frequencies, the magnitude of the contraction pain, all of that, okay, you're also going to also take a look, has there been a rupture of the amniotic sac, okay, which is what we refer to as the water break, okay? Is there any blood shown in the mucus of the amniotic fluids, right? Any of those signs? We're also going to check whether or not there is pain in the lower abdomen, because remember, false contraction, the abdominal pain happens in the front of the abdomen near the groin area. But true contraction happens stemming from the lower back and radiates all across the side of the body like a waistband, okay, into the abdominal area. Okay, so pain location, how did it describe the pain, whereabout is the pain, can also give you clues about whether it's fake or false contraction. Okay, now physical assessment also include what we refer to as, again, now we're talking about skills, okay? So we understand about signs and symptoms, okay? We understand diagnostic tools, right? Also monitoring tools. We're gonna take a look at some nursing skills here, which we refer to as the Leopold's maneuver, okay? Now, this is a skill that is non-invasive, but it's very technical skills. You have to perform this in 4 maneuvers prior to placing a fetal monitor or perform a vaginal exam of the patient. So what does that mean? Now, maneuver 1, as you can see here, the first maneuver, okay, it involves, it involves a gentle palpation, okay, around the abdomen to identify which fetal part is present in the fundus, okay? And what is the fundus? Basically, curve your hands around the very top of the uterus, okay? That will be the fundus, okay? All right. So you basically need to just kind of be able to feel it, okay, around the abdomen, all right? Remember, you are just feeling, okay, the positioning of the fetus, okay? If you feel a mass that is soft, asymmetrical, and lacks a distinct continuous border, you are likely feeling the buttocks, okay, the butt cheeks, which is what we refer to as a breech, okay? Now again, don't worry, this video explains it much easier than I am, but I still just have to go through the step with you, okay? Now that's first maneuver. Now, the second maneuver involves separating whether or not the fetal spine from its limb to determine the position of the back. So you're basically kind of feeling where is the baby's back facing? Is it lining up with the mother? So like that's the mother's back, so that's the spine. And then that's the baby's back, so they're lining up together, or the baby's back is to the side, or the baby back is actually curved downward. Okay, so the exactly so the fun exactly well that's exactly what we mentioned, right? It's the top of the uterus, so the fundus. Okay, because you need to kind of feel what is sitting on top of that fundus, right? Is it the head? Is it the chin of the baby? Or is it the bum of the baby, right? The bum? Or is it the shoulder? Okay, so those are the typical orientation of how the baby would be sitting right on top of the uterus where the fundus is. Okay, so we're basically taking a look at whether or not the baby is head out first, chin out first, bum, their bum, their butt cheeks, bum out first, or are they their kind of like their shoulder first, like on the sideways. Okay, but the second thing we're looking at, the second maneuver, is where is the baby's spine lining up? Is the baby spine lining up with the mother, or is it to the side, or is it actually like low, like facing downward because of some typically when the baby is bum down, okay, bum down to onto the fundus, then it's likely the spine is actually not lining up to the mother at all. Okay, so we're going to take a look at those differences. So we look at the orientation of, is it head out first, or is it bum out first? Is it chin out first or shoulder out first? Where is the spine of the baby located? Now those are the two maneuvers. The third maneuver, okay, I see a question, but Anne, I'll get to that. Just give me 1 second. Let me just go through the four first. I'll get to that, okay? The third maneuver will confirm the fetal position and enable the measurement of the weight and also the amniotic fluid content, okay? Because remember, the weight of the baby is encapsulated within the amniotic sac, okay? So how can we be able to measure the actual weight of the baby in addition to the amniotic fluids? We need to be able to kind of tell that apart. Also, then the fourth maneuver involves what we refer to as checking the fetal presenting part is engaged in the mother's pelvis, which means, do you need to change that physical position of the baby? Because as we remember, okay, depending on where the positioning of the baby is into the pelvic inlet, if your fingers slide down the fetal back and encounter an abrupt bony structure, for example, you hit the cephalic prominence, okay, this means the head is extended, okay, it's extended, which can lead to a very difficult face or brow presentation. Or if you're doing your, while you're doing the maneuver skills, your fingers slides down to the back smoothly and encounter the prominence on the opposite side, which means the legs, like not the legs or the arms, the limb side, then the fetal head is well flexed into what we refer to as the vertex presentation, which is the safest fetal position it can be for delivery, okay? So those are what we refer to as fetal positioning, presentation, and also station that we can obtain through the Leopold's maneuver assessment. Okay, so I have some questions. So Anne, first you have your hand up, and then I will get to Yuji's question. Anne, go ahead.
Yeah, just to clarify the first maneuver, let's say the baby is breech.
Yep.
That means the foot is down, the head is up, right?
That's right. Yep.
So the fundus being the top of the
Oh no,
uterus.
breech is actually the bum, the buttocks. The buttocks is
okay.
the buttock is sitting right on the fundus. Yeah.
Okay, so either one, like let's say it's the bum that's making contact. At the fundus point, though, isn't that the upper abdomen? Wouldn't you feel the head at the top where the fundus is?
We hope, we hope, but sometimes if, like, let's say for example,
No, I mean like in breech.
yeah,
the bum is like at the bottom, that's touching the cervix. Isn't the fundus the top of the uterus and the cervix
Top.
at the
Yeah,
bottom? Right.
exactly.
So if they're in breech, you would feel the head at the fundus, correct? Not the bum?
No. When we are talking about the first maneuver, we're basically feeling what is on the fundus. Okay. So if you're feeling the buttocks of the baby in the fundus, how would you be feeling the head in the fundus then? Because that's where it's situated. It's the buttocks of the baby.
So if you're feeling the buttocks at the fundus, then that means that the baby is not breech because the head is pointing down to the cervix.
That's correct.
Okay, perfect. Yeah, I just want to understand.
Yeah, because I was like, wait, like you gotta have to understand sort of where is exactly the actual positioning of it,
Yeah.
right? So if you're feeling the butt, you won't feel the head at the same time.
Oh, I know that. I just
Yeah, okay.
Yeah.
Okay, I just want to like, wait, hold on. I just want to clarify. Okay.
Yeah, because when you were saying fundus earlier, I thought you were saying like that's at the bottom of the uterus, but I was
Oh,
just
no. That's
clarify.
the fundus is exactly. That's on the top of the uterus. No.
Thank you.
No problem. Okay. So Yuji's question, do we get to practice any of these skills in our labs, even though we will not be doing plays and fart? Unfortunately, that might not be in a skills lab base opportunity. But yeah, unfortunately, that isn't available in the skills lab opportunities. So yeah. Okay, all right. Now I'm going to show you this very quick video in regards to the Leopold's maneuver, which tells us exactly sort of the positioning and the fetal presentation, positioning, as well as station. Let's take a look very quickly, and then I will be able to come back, just wrap this section up a little bit in regards to, and then I'm going to send the class to a quick break, okay? So just don't worry, it's only a 5-minute video, okay? So stay tuned. Oh, sorry, wrong button, sorry.
Hi everybody, welcome to Beautiful Nursing's 5 Minutes or Less series on fetal positions, presentation, and stations. And today I have my co-host Gina. So what even is fetal presentation? Fetal presentation is the part of the fetus that enters the pelvic inlet first. So this here is a maternal pelvis, and this here is Gina. Gina is going to be showing us how she's going to present to the world. This fetal presentation of Gina coming out head first is the most preferred. So then if Miss Gina was coming buttocks or feet first out of the pelvic inlet, meaning that this is the first thing we're going to see when she is born and birthed to the world, that means she is breech. Breech bad. Breech bad. Remember the B's. Breech bad. Next way that Gina could present to the world is scapula. So shoulder first. First thing I'm going to see when the baby is being born is her shoulder. Mentum, the first thing coming through that pelvis is chin first. So again, fetal presentation is just which way that Gina is going to present to the world first. Okay guys, so you're probably going to see all these different letters, ROT, LOA, all those stand for different things. So we are going to go through in different steps on what those mean and how you can figure out by looking at a baby or looking at a picture on an exam what position the baby is in. Step 1 is where the first letter is going to be an R or an L. So you're asking yourself, is the presenting part on the left or right side of the maternal pelvis? So as you guys see here, here's the maternal pelvis. Let's say the baby is going head first, so occiput. So is the baby going to be turned to the right or left side of the maternal pelvis, R or L? Step 2, you want to figure out what the presenting part is. So what part of the baby is going to be first presented to the world? Is it going to come buttocks first? Is it going to come head first? So again, that's looking at occiput or head first, sacrum, buttocks or feet first, mentum, chin first, or scapula, shoulder first. Okay, and then finally step 3, you usually see the letters A, P, or T. A for anterior, P for posterior, and T for transverse. Is the baby's back towards mother's belly, anterior, back towards the mother's spine, posterior, or sideways. Anterior is the baby's back towards the mother's belly. This right here is the front, right? This is the front of the mother, this is the back. If it's anterior, that means its back is going to be towards the front of the mother. Gina again is Gina's back towards the mother's spine. So they're aligned together, posterior back. Gina's back is towards mama's spine. Instead of Gina being anterior or posterior, Gina is going to be transverse. So she's going to be sideways. So let's talk about fetal station. What is fetal station? The fetal station is the relationship of the presenting part, so this could be the head or the buttocks, to the maternal ischial spines, and that measures the degree of descent of the fetus. So how far the fetus has descended down the maternal pelvis, how soon the baby is going to be coming out. Here's the maternal pelvis. So if I turn it over, you can see these two little spiky parts right here. These are the ischial spines. And so we're just looking at how fast the baby is descending down the maternal pelvis in order to be born. Here's the maternal pelvis. I turned it around so you guys can see the ischial spines right here. And if Gina is up here, that means she is negative. She's above the ischial spines. So if she is descending down the birth canal, she is going to become more positive. And once her head or her foot, whatever the presenting part of Gina is, once it reaches the ischial spine, so it's right at the ischial spine, that is when she is at 0. Gina continues to make her way down the birth canal. She is going to become more positive. Negative, 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 negative. Oh, neutral, neutral, neutral. Positive, 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 positive. Positive. All right, guys, I hope you learned something. Thank you so much for watching. Me and Gina just want to say please subscribe.
Okay. That's what I mean. She will have a way better visual than as I am explaining it verbally. Yes. All right. Awesome. Andreen, you have a question. Go ahead.
For the first one that says R or L, what
Yeah.
if the baby is not R or L?
Well, then it will, no, it depends on what it refers to RRL, okay? Because then if it's no RRL, then it's either face down, okay, and or back on, but you were still kind of, you would be able to refer that to as whether, because you wouldn't be able to totally be neutral, face down, or if you would still be tilted on one side. So there still would be a distinguishment of whether it's right or L. Exactly. Because you got to go through the inlets, right? So you can't be staying in neutral. It won't fit through anyways, right? So it will still have a distinguish between L or R, basically.
Okay.
Yes. Okay. All right. Okay. So we have baby Gina right here, as you see just now. And I'm just going to go back to our slides right here. Okay. All right. So as you can see here, the fetal positioning, presentation, and stations are important understanding for us during the labor processes, because you need to really be able to know exactly the positioning in order to know whether or not it is going to be a safe birth. Now, safe birth, again, it's not eminently 100% guarantees, okay? However, like mentioned by in the video, if it's the buttocks presenting first that is entering into the birth canal, you will be expecting this as a risky birth, meaning it's going to have a lot of associated complications during the birth period, okay, during that birthing process. The reality is positioning does make a difference in terms of whether or not it's going to be a more complex or less complex birthing process, okay? And fundamentally, what we're trying to ensure is whether or not the baby is safe in that positioning for the birth process to occur. In numerous occasions, okay, or even during my practice, and that's what I mean by numerous occasion during my practice, there's been emergency cesarean needs to be called upon purely because the positioning of the baby is not the most ideal for a safe birth delivery. Because also too is the umbilical cord placements that we are continuing to be able to monitor through ultrasound monitoring. So the position in addition of the fetus, in addition to the actual umbilical cord placements, will always be one of the most key fundamental decision making for whether or not a emergency cesarean surgery needs to be performed. Okay. Have you ever turned a baby around in the womb? Oh, all the time. Um, I can only tell you one of the most interesting experience I have had was so the baby was fine, like head down, ready to be into the labor process, but then suddenly it swim back upward to the mother's. I'll just keep it at that. Okay. So what do we have to do? Yeah, we do have to. Yeah. So we're like, okay, seems like the baby doesn't really want to be out yet. Just swim right back upward. So let's do a little maneuver positioning change, right? So yeah, that was a very interesting experience that I had. So it was well, yeah, looking back it was funny, but in the moment it was very stressful, right? But wasn't ready for the. Yep. Yeah. Seems like it, right? Okay. All right. Yeah, very cozy. Yeah, yeah, we mentioned that too. Yeah, it's like, yeah, baby's too comfortable in there, mom. So, wanted to take some more time before coming out, right? So, yeah, that was a very interesting experience for sure. Yes. Okay. Alrighty. Okay. Now I'm just gonna pause right here. Okay, because then the next component, the next slide that we have here on physical assessment, we have very much talked about it already throughout our slides to now. So I'm just going to pause here for a quick break, everyone. Okay, I know it's already into an hour and a half into our time already. So let's go for a quick break. Now it's 10:42. I'll just say 10:45. All right. So let's come back. Let's have a 15-minute break time. We'll come back and reconvene here at 11 o'clock. And then we're going to continue to look at what are some of the fetal monitoring that we would have to look at throughout this whole labor and delivery process. Because we've talked about sort of the birthing process. What do we look at and what are the signs and symptoms we need to monitor and look for in the mother's side of things. Now we're going to change our perspective into sort of what are some of the fetal monitoring, or what are some of the observations and also diagnostics that we need to look into in terms of the fetal side of understanding. Okay. All right. So enjoy your break. We'll be back and reconvene here at 11 a.m. See you in a bit. Okay, everyone, welcome back. All right, just give a bit of time as we get back to our lecture. Okay. Sorry, I accidentally exited myself from the meeting, so I actually had to relog myself on just now too. So sorry about that. But now we're back. Okay. So this is exactly where we left off. So we talked about the physical assessment in the previous slide, which, like I mentioned, we have talked a lot about it already throughout the beginning of the lecture already. Now, I wanted to hone into a little bit more into the fetal monitoring. Okay. Oh, can you? No, you can't hear. Can everyone hear me? Okay. Sorry. Just wanted to make sure. Yes. Okay. Perfect. Okay. Thank you. Thank you. Thank you, guys. Thank you. All right. Yeah. Sorry. I thought like, oh my God. Oh no. Perfect. Okay. Good. 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 Awesome. All right. So in terms of the fetal heart monitoring, okay, Yuji has a question. Did you have a question, Yuji? No? No? Okay. That's all
That
right.
was a mistake.
Okay. No worries. No worries. All right. Okay. Yes. Olamayo, try to leave and join again. Sorry. I don't think it's on my end. So maybe just give it a try again. Log in again. Okay. So we're going to talk about the fetal heart surveillance. Now, it's important for us to understand that this is a guideline, again, from the Society of Obstetrics and Gynecologists of Canada. The fundamental understanding about fetal health surveillance is the fact that there is a difference between low risks pregnancy versus high risk pregnancy. Now, according to the guideline, we do not prefer to hook a fetal monitoring to every single pregnancies, okay, like to every single labor, basically. Reason being, for low risks labor, it is in fact statistically show it actually creates more risks for cesarean and operative delivery if low risks labor are being hooked onto a fetal monitoring. So instead of fetal monitoring for low risks labor, we do encourage what we refer to as auscultation. Okay, so intermittent auscultation. Now, when we perform intermittent auscultation, you don't look at a monitor. You actually use a handheld Doppler. Okay, you will have to adhere to strict protocols. Again, even though there is the guideline established by the Society of Obstetrics and Gynecologists of Canada, you still need to make sure you refer back to your policies, your organization's policies, okay, because you wanted to make sure. So what we refer to as using that handheld Doppler, you will listen to the fetal's heart rate for a full 60 seconds, so 1 minute, basically, typically immediately after a uterine contraction. So the question is, why right after? Because when the fetus experiences stress, which is the contraction, that force, okay, the fetus will experience that slight magnitude of stress, which the heart will respond by dropping in response to the contraction. And being able to assess and auscultate right in that stage or that period of time right after a uterine contraction will give us the understanding of whether it does respond to the contraction, which means is it healthy responses, okay? So taking a look at intermittent auscultation, you typically will do that on a 15 to 30 minute frequency at the first stage of labor. So remember I mentioned how that labor weight can vary in duration from person to person. So at the very beginning, the intermittent auscultation can be done on an every 15 to 30 minute basis. You don't really need to worry too much about being too frequent. However, as the labor continue to progress and advance, you will need to auscultate every 5 to, let's say 5 to 10 minutes, or even after every single pushing contraction. Okay, and because remember, contraction can happen on at a very different rate depending on the stage of the laboring process. So you do have to kind of time that accordingly with the handheld Doppler to perform the intermittent auscultation. Now that is for low risks labor. Okay, like everything goes well, fetal position, etc. Right, the mother is tolerating well, etc., etc. All of the determining factors for it to be a low risk labor. On the other hand, with high risks labor, okay, such as, for example, labor that requires oxytocin for an induced labor, that in itself is actually a little bit more higher risks, okay? It will then require what we refer to as a continuous electronic fetal monitoring, okay, the EFM tool, which we've mentioned about it briefly in earlier slides. Now, once the fetal monitoring is running, it's hooked up and it's running, you need to be responsible to analyze the digital and paper strip from the machine. You need to be able to take a look at it, whether it's being as normal, as you see here on the slide, normal, atypical, abnormal, all right? So how do we distinguish between these three categories? Now, a normal tracing, okay, is great. It's reassuring, baby's doing well. The baseline fetal heart rate should be about 110 to 160 beat per minute. Variability should be no more than 25 or less than 6. It should accelerate. Remember, after that uterine contraction, as you were able to see sort of the highs and lows, the deceleration should be none to early, okay, depending on sort of as it continue to progress into the laboring process. When it's atypical is what we refer to as the baseline heart rate is between the 100 to 109. As you can see here, is closer to the lower end of the range, okay? Minimal, oh, sorry, I just noticed that they turned it into different symbols. I have to insert the symbol individually. Sorry about that. Okay, so for atypical, okay, now for example, if the range is between 100 to 109, okay, so just mentioned to give an example. If the baseline of the heart rate changes from, let's say, 100 to 95, okay, because it should be no more than 5 beat per minute for less than 40 minutes, okay? So let's just say, if the monitor is showing the heart rate, the fetal heart rate has now reduced to 95 beat per minute, or even 94 or 90, okay, beat per minute. You are sustaining a baseline variable beyond the 5 beat per minute range, okay? So what we mean by variable is you can tolerate the differences, okay? So for example, if the heart rate has now turned it into 95 beat per minute, okay, you are able to tolerate that. But if it continued to decline, let's say to 92, 90 beat per minute, you're gonna have to worry about is that this is atypical monitoring of surveillance, because reality is you are expecting a decelerating of a heart rate. Okay, because really what you can really just kind of take a look at is the fetal heart rate as the basis of measurement. Now, if it's normal, we're talking about the acceleration or the baseline variable should no longer be more than 25 or less than 6, for example. So the 6 to 25 beat per minute variation is still okay. But you might ask, well, if the baby's baseline heart rate is already at 160, you add another 25 to it, that you are basically taking a look at, sorry, I just have to admit someone in, hang on a second. Sorry, okay. All right, so if you're adding 25 to it, you're basically looking at 185 beat per minute. Isn't that too fast? Like, wouldn't that be? Mind you, you're referring to a fetal heart rate baselines, okay? Of course, we do not want it to be at 185, but it is tolerable during the labor process, provided because it is under tremendous stress upon every uterine contraction. So please keep that in mind, is that even up to 195 or even 190 heart rate per beat per minute, it's still a tolerating fetal heart rate as normal. Now, when it's atypical versus abnormal, now this is the key we have to hone into. As you can see here, abnormal baseline heart rate is less than 100. Now, as you can see here, even for atypical, it's still bordering the 100 line. Okay, the lowest is still bordering 100, just like the normal would be. Okay, it's 110. But for abnormal fetal heart rate is anything below that 100 mark. Okay, because remember I mentioned your variability become 95, become 90, 91. That's a concern. Okay, because that will jump you right into from atypical monitoring to abnormal fetal heart rate monitoring. Okay, so that in itself would require attention right away. So remember, we're not asking you to know exactly what you need to do, but we need you to know exactly what you're assessing for and when is considered a medical attention right away moments. Okay, so in here for atypical or abnormal tracing, that's a critical clinical event, which means when the baseline drops below 100 beat per minute, or stays way above 160 for longer than 30 minutes, there is no variability in between, okay? Because technically your heart rate should fluctuate, okay? The fetal heart rate should fluctuate because remember, there's contraction pressure at every given moment, right? So you should expect the heart rate to vary, but it shouldn't be more than the 6 to 25 for normal variability. Okay. However, provided that if the fetal heart rate is below 100 for longer than 30 minutes, that is definitely a attention right away moment. Or if it's beyond the part of, let's say if it's lower than 90 for longer than 30 minutes, absolutely attention right away. If the heart rate is above 160, because remember the normal heart rate is to 160 beat per minute. If it's sitting above, okay, for like 175, 180, for longer than 40 minutes, that's also a critical moment that requires medical attention. So the key marker here between an abnormal versus atypical versus a normal health surveillance of fetal heart rate is whether or not there is any deceleration. As you can see here, normal fetal heart rate will have none or early deceleration. Atypical can vary, okay? It can happen at various different patterns, but if it's on a steady deceleration, that is also a key trait for abnormal fetal heart monitoring, which means they begin after the peak of the contraction and return to the baseline long after the contraction has ended. So remember, we should expect that deceleration right immediately after the contraction, but it should come back to baseline quite quickly. But if that response remain and retain for a period of time, give or take 20 minutes, okay, 20 to 30 minutes, right away, medical attention. Okay, because what it is that this is likely an indication that the placenta cannot maintain adequate gas exchange during a contraction and the baby's oxygen reserve are depleting, which then affects the fetal heart rate. So when you identify a abnormal tracing from the electronic fetal monitoring, you need to initiate right away medical attention and also potentially intrauterine resuscitation because of the gas exchange reserve have been likely depleted as a result. So very important to keep those in mind of what you are monitoring in terms of the electronic fetal monitoring. What are the variability that it's allowed, that is an acceptable range, versus also the changes after every contraction. All right, Andreen, you have a question, go ahead.
Yeah, I'm a lot confused, but let me
No
just
worries. Let's
explain
try
what
that out
I
again.
understand and see if that's what you're saying.
Yes,
So initially, we have to get a baseline, preferably not directly after a contraction for the fetus, right?
that's right.
Then after that, depending on what we get, we'll determine if it's normal, atypical, or abnormal. And then we would monitor like every 15 to 30 minutes
Mhm.
to get whatever variability after to see if it spikes by the 25 or over the 25 to determine if the child is in, the fetus is in crisis or not. Is that
That's
what you're
right.
saying?
That's
And
correct.
then we
I'll now
also
just add to
look
that
at,
just a second.
okay.
Sorry, Andrea. I'll just add a little bit to that. It's to the fact that once you have that baseline, you also need to monitor because right now you're being the mother is being hooked to the electronic fetal monitoring. You also need to take a look at the changes right after a contraction has ended
Mhm.
to see if it's within that tolerable variable range
Right.
to the baseline. Yep.
And then after that, we have to determine the acceleration and the deceleration, whether it's their heart rate is reducing back to baseline within that time frame, whether we're in the abnormal, normal, or atypical section, right?
Exactly. Yep.
Okay.
Exactly.
All
And
right.
if the acceleration or deceleration is being retained for a long period of time, so typically we say the 20 to 30-minute mark, that is going to be of concern. So depending on whether or not it continues to be retained that way, because within that 30-minute mark, you for sure is going to experience another contraction, right?
Right.
So technically, if another contraction occurs during that time frame and the deceleration it's still being retained, then that means it's going to be a medical emergency.
Okay.
Exactly. Yeah. Because during the wait of the 20, 30-minute, you're bound to experience another contraction at least once or twice more. Okay. And if that after those subsequent contractions, the deceleration still continues, then you have now from atypical transitioned it over to a abnormal fetal monitoring. So that's sort of how we distinguish between the three categories. Because as you can see,
But
the deceleration for normal should not be there. You see the
uh,
deceleration on the chart?
okay,
It's
because it's
none or
seconds.
early.
So
Yeah,
it's seconds, so that's why it makes sense now. Because I'm thinking, oh, if we're gonna have another contraction and then the child's heart rate should still be decelerating, then that doesn't make sense. But because I realize now it's not minutes, it's seconds. The variables are seconds. Okay, got it.
exactly. Okay, good, good, good. All right. And so that's why, like, I specifically have a whole slide of its own dedicated to the fetal heart monitoring because we talk a lot about the maternal health, like the mother's body's responses. We need to also be well aware because I always mention it's always a dual track assessment that you're doing, the mother and the baby simultaneously. And so knowing what we need to assess and monitor for the mother, we also need to know what we need to monitor and assess for the baby simultaneously during this whole process. Okay. Now, with that too, to add to that a little bit more, just to be a bit more thorough too, is to also be considering with pelvic evaluation, right? Like if there is any CT or MRI that can be done during the time as well too, but typically won't be considered unless it's a atypical and or abnormal fetal monitoring that has been found. Would the patient be then sent to a CT or an MRI for the fetal monitoring? But other lab samples can also be considered to help you during this health surveillance of the fetus is a complete blood count, also blood typing and screening. Again, doing that one more time in like the very last minute to make sure that everything is in line and in checked. It's also very important. And then monitoring for the uterine contraction. So remember, we mentioned again, there's no longer fake or true contraction here anymore. You're well into the laboring stage. So at this time, you are also just looking at to see as soon as the mother enters into the labor, whether or not the contraction will determine by the onset and the magnitude of the actual duration of contraction. All right. Is it getting faster and faster, stronger and stronger? And it's also more and more pain that is leading to discomfort of the mother, which is also, again, that pressure push that is being experienced as a result of the oxytocin release, okay, will become stronger and stronger. So it's not just the pain, but it's also that downward push that the mother will experience will also be much more prominent during this time. Okay. There's another question. There's, as an LD nurse, how many patients are you assigned on average? Good question. The time when I was, we have about 4 to 5 patients. Okay. As much as I know right now, because 4 to 5, yes. Because the reality is every case will take different periods of time. And so even though you may feel like, 4 to 5 it sounds like a lot, but they don't always happen all at the same time, right? So that's the reality of it. And you always work as a team. So we never work individually in L&D. In labor and delivery, because as soon as you are busy and engaged in a birthing process, like in a delivery, you are not going to be able to split yourself in half and attend to other patients. So you always work in teams. So it's good in that sense because it's a teamlet model. Once you are in there, then your partner will be covering for you during those times. So it's good in that sense because you don't often work in that kind of teamlet dynamic in other units. But in L&D, you work as a team. So once you are, let's say if one of your patient or 2 of your patients are simultaneously engaged in a birthing unit, like both of them are occupying 2 suites of the birthing unit, you would be running back and forth, okay? But there is always a partner there to be able to help monitor your other 2 to 3 patients, depending on the shift scheduling. So you will always be working with partners. At least that's still the case nowadays. As far as I know, recently, from what I heard, is the patient is now come down to 4 patients per nurse. I'm not sure why, but it's a good thing. Okay, so workload-wise is getting better. Okay, but back in my days, we have up till 5 patients at a time. Yeah. All right. Okay, so moving on. Now we're going to talk about nursing intervention. So we're going to talk various different things in terms of what we can do during this time, and also kind of what is our scope and context of interventions. The one thing will be, will be these cervical exams. Now, depending on the need of the actual labor, cervical exam is not always the most suggested. Reason being, you are just assessing to ensure whether or not the dilation is actually a good indication that the patient is entering into labor or not. So this is the extent of what we refer to as the cervical exam. In addition to, we'll be understanding about the fetal positioning. It's mainly through the Leopold's maneuver, which is really just palpate on the abdomen, not through the cervical exam. That is more a scope for the obstetrician. Okay, just so you are clear on that front in terms of scope of practice, especially during a time like this. It's very stressful. It's very immediate moment-to-moment responses. It's important for us to keep those in mind. And the other 2 will be all the preparation work, right? All the preparation work for the IV lines, right? Establishing the IVs, the insertion, making sure that the hydrations is also in place through the IV lines, all of that, okay? Also very important to keep in mind that it's our scope to prepare that patient is for sure it's going to be needed, an IV line. So make sure that the IV line is already in place. Everything of the IV system is up and ready for running, okay? Because as soon as labor starts, moment to moment, every minute counts, and it can matter as to whether or not we can respond to it quick enough versus not. So it's very important we have those preparation work done well in advance in anticipation for the labor process to begin. And Lorraine, you have a question. Go ahead. Lorraine? Or Lorraine, sorry if I'm not pronouncing it correctly. No? Maybe that's not real. Okay, maybe just a mistake for raise of hand. Okay, no worries. You can come back to it. Okay, so in regards to that, now we're going to talk a little bit of a softer skill. Oh, your mic is not working. Okay, no worries. Maybe you can type the question then in the meantime, while you can type the question in the chat then. During this time, a lot of comfort measure is a very important element. Reason being is that we need to ensure that the mother has the stamina and the energy in preparation for the labor process itself. Now, comfort requires a lot of different realm of interpretation, such as it can be maybe turning off the lights, keeping the room dark. It can be having a quiet surroundings, maybe lowering the machinery's operating sounds. That is possible, right? As we know, even in the IV, the Alaris IV pump that we've been using, right? There's also other elements such as music, also having family members be able to be there to accompany. How many of these accompaniment does the mother prefer? Okay, that's also, it's a varying pieces from patient to patient. You also want to encourage and advise the patients to have a walk around too as well. Though the gravity itself may cause further discomfort when they're experiencing the contraction, but again, being able to have that sort of movement and mobility does actually help to reinforce the stamina as well as sort of the physical responses that it's related. And also, we wanted to make sure that there is component to ensure comfort of the patient, such as pillows, clothings, also any other what we refer to as comfort measures, such as, so what I have seen are kind of like those like essential oil rollies that I have seen patient use. Some patient have candles that they light, in that the fragrance candle. Even though we are a fragrance-free hospital, okay, but the reality is we understand that sometimes some of these measures are helpful. We do make exceptions, but again, according to organization policies. There's also other cultural components too, where there is a cultural practitioner that comes in to help with the patient before entering into labor, et cetera, et cetera. So there's all sorts of different comfort measures that can be considered and to be respected as well. So those are just something to keep in mind when it comes to comfort measures, also to help with that labor and delivery process. Okay, so going back to Lorraine, sorry about that. I just want to make sure that I go through the slide, okay? So the question is, you said about the entry during resuscitation. What does that mean? Some slides back, not sure if it's something to know or didn't hear correct. Yeah, okay. So remember, the intrauterine resuscitation was mentioned during the monitoring of the fetus, especially too when there is, especially with the fetal positioning too. So that's where it was mentioned. Not that you need to know them in detail, so don't worry about that, okay? For the context of the course, we don't expect you to know what is the intrauterine resuscitation. We just need you to know and what type of situations would a resuscitation be triggered, okay? So for example, the abnormal atypical fetal monitoring, also the intermittent auscultation if you find abnormalities. There's also the fetal positioning, which link back to abnormal fetal heart rate monitoring, okay? Because like I mentioned, the fetal position does play a very important factor in terms of whether or not it's going to be a risky birth or not, okay? Those elements are the times when you would have to understand, to assess, oh, we need to initiate or trigger a intrauterine resuscitation because of these elements. We don't need you to know the full details of what that looked like. We just need you to know what would you be assessing that would trigger an intrauterine resuscitation. Okay, Okay, out of curiosity, how do they resuscitate if you have time? Okay, we will mention that in afterwards. So let me get back into the slide. We'll get back to it. Okay, so no worries. Now, in terms of comfort level, comfort measures, we also wanted to take a look at if the labor, it needs to be of a concern. Now, remember we talk about various cases from case to case. The waiting of the laboring process can vary from like hours, from like some people may only take 3, 5 hours, some people can take more than 10, some people can take more than 20. So depending on what the condition and the situation may be, that wait can vary quite drastically. Now, but to a point when that wait needs to come to a pause, right? Meaning it's been too long, it's taking too long, and the patient is still not going into true labor, then what? Well, then we will need to think about or prepare the patient into what we refer to as amniotomy, which is a part of the process for inducing the birth. Okay, so in addition to administering oxytocin, an amniotomy is also performed to help with what we refer to as the process for inducing birth. Okay, now, and what does that mean? I will show you a very quick video right here. So we wanted to just show you what that means. One second. Okay, so short and sweet, right? Very, very simple explanation. It's basically a way to poke a hole, okay, in the amniotic sac to induce a labor and delivery. Reason being, the less of that amniotic fluid is within the sac, especially after a breakage, that in itself will trigger the body to produce oxytocin. Now, sometimes it may be enough oxytocin release, sometimes there may be not. Hence, you see that there's also administering of oxytocin here as part of the process. Because remember, we mentioned oxytocin is a release, it's a hormone that gets released in the posterior pituitary gland that increases the contraction and the muscle contraction in the uterus, okay, in order to induce labor, basically, okay? So in that case, when this needs to be monitored. As soon as the amniotomy is performed, the fetal heart rate will be monitored on an ongoing basis because, as we know, the amniotic sac and the amniotic fluids, it's basically it's the main elements of keeping the fetal development and livelihood of the fetus. So as more of those amniotic fluid gets depleted within the sac, the baby needs to come out, meaning the baby needs to be born. Okay, now the risks and benefit to that, and just like you saw on the end at the end of the video, the pros and cons to this varies. Okay, now the pro of it is when that labor, waiting for labor process is taking too long, it actually can be an increased risk to the baby in many different reasons. But for simplicity of the context of the course, we don't need you to worry too much about that. But just so you know, the longer it takes for the mother to go in labor, the more and higher the risk it can be for the patient, for the baby. In addition to that is the longer the wait, the higher the chance the amniotic fluid will continue to be depleted. And as we know, the amniotic sac, it's basically the essential livelihood of the baby. So if the long hours of waiting to go in labor, it's still not happening, and more of those fluids are being drained and depleted from the amniotic sac, you're increasing the risk to the baby livelihood, okay? So therefore, an induction needs to be made, okay? So just to keep those in mind, the risks and the benefit to it is, okay, if we are doing an amniotic fluid, you're speeding up the process because of out of necessity. Now, at one point in time, what are the risks to it can be, because remember exactly how the videos showed you, it is considered an invasive procedure in a way because of that poking of a needle, right? So sometimes it also determined by the fetal position may or may not pose risks during the procedure. So there are some associated risks that can be involved in this process, but technically if we're weighting the pros and the cons, the pros is still more so than the con, because there may be a bit of an injury that can be resulted in the baby, for example. But again, very small minor injury that could occur compared to if the amniotic fluid is depleted and the livelihood of the baby it's basically jeopardized, right? So still weighing the pros and cons, the benefit of it still at times outweighs the potential risks as a result. Okay, so that is another part of nursing intervention that can be involved during the labor and delivery process. And last but not least will be pain management. Now, pain management is a huge component during the labor and delivery process, because pain during labor is a complex symptom. It's multidimensional, and its experience is a mix of physical sensation, emotional, psychological, and even cultural factors. So as nurses, our role here is not to impose any specific intervention, like not to say, no, you shouldn't take the pain meds, it's bad for the baby, like none of those, because what our role is playing is to support the patient's choices using an evidence-based approach. Now, what is evidence-based approach in the context of labor and delivery? Non-pharmacological methods can be, for example, reducing back pain by using any massage technique. If they do have midwives in there, there are a lot of manual techniques that can be in place to help reduce the pain. Okay. There's also active movement, pelvic rocking, so kind of the rocking back and forth, and also, side to side, also to relieve that pressing down pressure, right, into the lower abdomen. You're also utilizing birth ball too, right, to help redistribute the pressure in order to help alleviate the pain. Those are what we refer to as non-pharmacological, okay? Now, there are also some other cultural practices too, and the other ones that I've mentioned to you, like I mentioned, are like using essential oils. Like I've seen essential oils rolls or like sort of pieces too. Like those are also different strategies that I at least personally have seen. Now, some of the other pharmacological approaches are using IVs, okay? Using IVs, opioids during the time before the actual labor. Typically, we do not go use IV opioids during the actual delivery process, okay? We usually would pause within 1 to 2 hours before the actual labor. So that's why we always say, do not wait until the last minute. We always would encourage the patient to verbalize and voice their pain as early as possible. Don't try to just, keep it all to themselves. It's important because timing of when we administered and when to stop them right before the actual delivery does matters in terms of the outcome of the actual birthing process. Okay, so it's very important for us to keep that in mind, is to encourage the patient to verbalize their pain as early as they can. Okay, and then finally, you're also, again, not surprising, use of epidural. Okay, now epidural, oftentimes there's a lot of mixed beliefs and also kind of understanding as to when is a good time, when it's not a good time. Reality is there is no 100% guaranteed of a good time. All right. Epidural anesthesia, as we know, is a targeted pain relief that requires nursing intervention because it needs to be monitored. It's not something that you just provide, inject it, and then you don't need to worry about it. It's going to do its work, do its job. Nope, that's not the case. So the reality is there is no 100% right timing for an epidural. There is a reason for why we ask if the patient can wait for the epidural. Reason being, there is limited time to how long the epidural can last. Now, if the labor wait takes hours on end and the patient received the epidural too early, there may be a result where the epidural's effect fade out before the actual birthing process takes place. And so with epidural, we are practicing in a slightly different approach than other pain management, is that we always ask for, is it possible for you to wait for the epidural, because we know that there's limited time window for how long the epidural can last. And we always wanted to make sure to time that window falls right into the time when the actual birthing process takes place. Otherwise, the patient would have received the epidural, but never really received the benefit of the epidural during the birthing process. So that's the only thing, okay, that I would mention to remind you, the class, to just keep those in mind, is that other pain management, we always encourage the patients to verbalize early so that there's a plan in place so that we can keep monitor, right? So there's enough frequencies to help manage for the pain during the process. But for epidural, it's just slightly different approach, is we always would ask, can it wait? Right? We always time it based on also the frequency of the contraction, because that will tell us, you know, how much is it closer to the actual birthing stage, versus being too early, the patient would have received the epidural but never reaped the benefit of it during the birthing process. So that's the only thing that I would like to remind the class about that would be important for us for nursing interventions to keep in mind for. Okay. So this video, again, it would be very good for you to take a look at. I won't play it during class for now, because I do wanted to make sure that I spend some time. Sorry, it's almost noon already today. But I also wanted to spend some time to talk to you about preventing complications. Now, again, for the context of the course, we're not expecting you to know every complications, okay? But we just want you to just sort of have an understanding of the different types of complications that could occur during different stages of labor. So during the first stage of labor, like I mentioned, that weight can vary. Okay, so women that may experience arrest of labor during their first stage, okay, because again, that in itself would trigger a medical necessity for a cesarean C-section, right? But during the second stage of labor, for example, some of the, but during the second stage of labor, which is again getting closer to the actual birthing process, there could be brain damage, because depending on the fetal position, right, there could be a potential for brain damage or asphyxiation, low blood pH, shoulder lodged in the birth canal, because again, fetal position is very important. That's why we focus on that. We talked about that, right? All of those are potential complications that could occur during the second stage, okay? Now, remember, the key component here is, yes, we acknowledge these are the potential complications during different stage of labor, but the key pieces here is that once that symptoms of the fetus that is showing abnormalities or deterioration of the condition, a cesarean a C-section will always be considered as medical necessary, okay? And so, again, preferably, the main go-to by standard guidelines is vaginal birth, but medical necessary, then in situations, C-section would be implemented, okay? And then third stage of labor is typically associated, because remember now, you are getting into more closer into the actual birthing process. The third stage is typically hemorrhage. So if there's a massive hemorrhage occurring before the baby is even born, again, medical complications that needs to be addressed right away. Cord avulsions, of course, right? C-section. Retained placenta, again, the livelihood of the baby is through the placenta and the amniotic sac. So if that is at risk, emergency attention right away. Incomplete placenta evacuation, again, same thing, medical attention right away. Okay, so we don't need you to know the full details of these complications. We just want you to be well aware to know what to assess for that are potential complications that can occur during the labor process. All right, and that is all for today. The last slide is just a quick reminder to everyone that the virtual sim is due by this Sunday, okay? And just make sure you review the content of this week's module. And that is it for Module 2. Any question? Okay, yes. Almo, go ahead. Oh, am I not hearing something? No, is the mic not working again? Oh, how would you say we should begin studying for the Okay, yeah, that's a good question. Okay, so okay, so the immediate, so Almo, I can't hear you, so maybe you wanted to just double check, but I'll get back to you again. But just to answer the question here, Narushin, how do you study for the midterm? Now, before you even get to start studying the midterm, I think, as you can see from the EAQ quizzes, are very helpful to help you understand the readings, okay? So the readings are important in the context of you understand the nuances of the topics that we talk about. Now, for those that are important, of course, we mention and talk about it in class during the lecture, but we cannot possibly have all of the details covered during the lecture time, right? So readings then become very important to supplement that knowledge base. So readings, of course, again, fundamentals, complete the readings, complete the EAQ quizzes. That would be very helpful to help you solidify the knowledge from the readings. And then coming into class to be with that preparation of knowledge will also help further for you to understand the content. Now, when it comes to studying for the exam itself, there are various different types of questions. We do try to push it into more of a NCLEX style question type. So very clinic based, you will see a lot of different signs and symptoms and of a case scenario. What are the interventions? Because again, remember I mentioned here, we're not expecting you to really know the nitty gritty of every single components, but you need to at least understand what are the general assessment data, what are you looking for, how can you observe, obtain those assessment data, whether it's through lab results, whether it's through assessment, whether it's through observations, etc. All of those needs to be encompassed within your knowledge base to be able to apply those to the questions in the exams, okay? So again, it's very application based, but that also, which means you need to know the knowledge inside out, okay? But just not in the nitty gritty details, okay? Like I repeatedly had mentioned during lecture today, okay? So there's, so almost, oh, okay, so Almo, I guess your mic doesn't work, right? So the virtual sim, would you like us to respond to a question in standard APA format, making a title page, or simply respond to a question including APA and citations and a reference page? Okay, that's a very good question. Now, I would say what might typically expect would be an APA format, but for the sake of this first one, I will keep that as a little bit more open. I am more interested in your own experience after learning through the modules and actually played the game that is interactive, because the game itself is different outcome depending on your decision making. So for this virtual sim, I would say I am looking in more to your authentic responses. But for the second virtual sim, it will be APA format regulated. Okay, so I just wanted to clarify that. This virtual sims, it's really about what are your gameplay experience that you have identified to answer those questions. But for virtual sims 2, it will be APA format for sure. Okay, and then also coming back to Anne, can you share a bit about the intrauterine resuscitation? What methods are used? Yes, okay, yep, no problem. Okay, so for intrauterine resuscitation, okay, I will say I do not have the full clinical knowledge of it either, unfortunately, because that is actually outside of our nursing scope, okay? Now, we do not perform the intrauterine resuscitation, unfortunately, at least within our practicing scope in Ontario, but we are responsible to initiate the request for it. typically in hospitals, we do require, upon triggering the resuscitation request, either a gynecologist or a OB, we call it the OB, the obstetrician, will perform the intrauterine resuscitation, which typically requires 2 physicians' help. Typically a OB and a fellow, right, which is the resident. Now, usually what happens, we do not get into, because again, I personally did not get any clinical experience to that, so I'm sorry, I can't really speak to that. But as far as the context of what it involves is that it cannot be performed at the birthing unit, okay? It needs to be performed within the, not in the, it cannot be performed in the usual patient's room. It has to be performed in a birthing unit, as if it's like sort of like a code blue that needs to be performed. The reality is that intrauterine resuscitation are very rare occurrences, okay? We would say probably once in every 50 pregnancies would that require an intrauterine resuscitation, because as long as we continue to do the monitoring in advance, ahead of time, it can significantly reduce the chance and the risks of intrauterine resuscitations need, okay? So those are what we refer to as the guideline, always say, when you intervene and monitor it early, it reduces the risk of intrauterine resuscitation significantly, okay? But the one thing I will say, okay, is that typically if it requires an intrauterine resuscitation, the birthing process is significantly much riskier, all right? And I can't say definitively, but there's a very high chance if the resuscitation is needed, it's likely going to get into a C-section almost all the time. All right, so that's all I can say. So sorry about that. I don't have too much of a clinical experience personally in my practice, but that's typically is when that is triggered, okay, we know that it's our responsibility to trigger that resuscitation code. And then also likely if that does happen, it's likely going to end with a C-section, unfortunately. Okay, so there's more question about, good to know. Yeah, is there a time window for requisition or is it requested stat? No, it's request stat. No time to wait. So it's always a code that we called in the labor and delivery unit. Yeah. Okay. And Anika, you have a question.
Yes. Hi.
Yes.
My question is, so for the EAQ quizzes,
Yep.
they're closing at 12:59 p.m. instead of 11:59 on the Sunday.
Oh, that has already been fixed. So yes,
Okay.
thank you for letting me know. Yeah, I think that.
Okay.
Thank you. Yes,
No
I think
problem.
module 2 quiz became 12:59 instead of 11:59. But yes,
Yeah.
thank you for bringing to my. It
No
has already
problem.
been adjusted. So thank you.
you.
You guys have 1 extra hour, I guess. Okay. But yes, thank you so much. Yeah, so as usual, remember the virtual sim #1 is due by the end of this week, okay? So for this one, I am more looking forward to your authentic responses from the gameplay experience that you have after going through the learning modules. But for virtual sim #2, I will be expecting APA format, okay? So don't worry, I will make sure that it's APA format. Expectations, it's on the virtual sim submission portal, okay? But for this one, I am more interested in your experience after the game, because the game is actually pretty well done. So just I hope that you get some good learning experiences from it. Okay. Now the other piece too will be then for next week. We are going to be joining in again, synchronous again, online. So as you know, you know where to find the Google Meet link again. For next module 3, there is a EAQ quiz again. So make sure you do complete that by Sunday, okay? And your assignment part A, okay, your first part of your group assignment is also due by next week. So please make sure that you keep that in mind. I will remind you again next week, of course, okay? But just wanted to give you more time notice, okay? Your part A of the group assignment is due by the end of next week, okay? So just keep that in mind. So Sarah has that weekly notes. Will all information to fill them be found on Canvas, or is there someone involved, okay? Are the weekly notes a good guide to use to study for the midterm? Absolutely. So the notes are created for a reason. It does help for you to go through the lecture materials in addition to some of the reading materials too. So we're having those notes here to help with the lecture component as well as the reading. The EAQ module quizzes helps with the reading. So you're getting multiple sectors of different tools and help to help consolidate the materials. I understand it's a lot of materials, but again, like I mentioned in the first week, this is probably your first and only pediatric related course, unless you are going to pursue the advanced pediatric course later in the years, right? So, but otherwise, this probably will be your first and potentially only opportunity for child and family health. So just wanted to make sure we have all those components available for you. Okay, so the comprehensive patient profile, do you want us to go straight into the profile or provide background or condition as well as before beginning the profile? Okay, so good question in terms of, is it necessary? I would say if I were one of you, okay, to approach the assignment, absolutely important. The reality is when you're providing me the patient's profile, you are actually also presenting what is the potential problems that you're going to anticipate. Because in your part B of the assignment, you're going to identify 3 problems that you're going to intervene with SMART goals, right? So as you imagine, and one of that needs to be a teaching tool. Okay, so I would say they're equally as important. So the background and the profile, because sometimes what I do notice is that some groups will give me the patient's profile, but doesn't give me the background, which lose the context of the social determinants. And then suddenly in part B, they talk about malnourishment. And then I would be looking at, wait, hold on, but none of the patient's profile had mentioned about malnourishment. But because they haven't talked about in the background of the patient's profile is the fact that the patient experiences a job loss or like a socioeconomic status, etc., which then explains why there is a malnourishment problem that has been identified in part B. Okay, so I would say if I were one of you, I much would provide both the background as well as the profile altogether to give more of a comprehensive explanation about the patient, which in a way will help you for your part B anyways of the assignment. Okay, so last question, is the group assignment okay if the resource is dated 2013? Okay, remember I mentioned specifically within the assignment description, 5 to 10 years is the max. Okay, so 2013 is slightly outside of that frame already, unfortunately. Okay, so I would say that wouldn't be my first choice if I were a member of the group, unless you are telling me there has not been any update of that knowledge since 2013, then that's a very different story, okay? But typically I wouldn't say, I would say if it's outside of the 5 to 10 years mark, just don't use that as your priority reference, okay? So there's another question. Notice the example tables on page 3 that outline individual student strengths, skills, group of 8. I want to confirm is required to include. Additionally, should we be following the format of the 2 tables provided? Yes, absolutely. So we gave you, I gave you an example there for a reason. And there's a reason why I made it into a different scenario, so you can't exactly copy and paste. I'm just joking. All right. But yes, absolutely. You have to outline who are your members, who are doing what responsibilities, okay? Now, in terms of strength, I wouldn't worry too much, but I do want to make sure that you do say, person A is the researcher, person B is the editor, person C is the, aesthetic, like presentation aesthetic designer, whatever, okay? And then underneath that, you also wanted to make sure that what are their tasks. So not only is the role being identified, you need to outline their tasks, okay? Just because you're a designer doesn't mean you don't help out with the research. Just because you're a designer doesn't mean you don't help out with editing of the presentation or the actual submission of the assignment, okay? So that's why I mean, I rather, like, in terms of strength, I don't really worry because obviously you are going to assign your members according to their strength. What I would really pay attention to is what are the roles of the group members and what are their tasks that they're responsible for. It needs to be clearly outlined so there's no room for argument for whether between yourselves and or that I will be hearing from the groups. Okay, so just make sure with that. Do you want to be in a table format? It would be great if it is, because then it just makes it a lot easier and easier to follow reading through it. So a table would be very helpful to organize those information. Yeah. Okay. Do we need APA cover page for absolutely everything except for the virtual sims? A1, okay, except for virtual sims number 1, everything needs to be APA formatted. Please make sure, okay? Because the virtual sim number 1, it's a game related, so I'm much more interested to hone into your game experience of what you've learned through that gameplay, okay? But otherwise, your group assignments, your part A and part B of the group assignments, as well as the virtual sim number 2 coming up later in the weeks, are all APA format expected. Okay. Yep, no problem, no worries. Any other questions? Good. I'm glad to see all these questions coming. That's good. All right, good, awesome. All right, so if there's no more questions for now, okay, so I will let you go, okay? But if there is any questions that you think of later in time, don't worry, just email me, okay? And then otherwise, have a good rest of the day, and we will see you all again virtually next week, Monday. All right, have a good day, everyone. Bye for now.